In a person with HF, the blood may not be adequately oxygenated, resulting in reduced O2 saturation. The use of supplemental O2 improves saturation and helps meet tissue O2 needs. This helps to relieve patient dyspnea and fatigue. Ongoing pulse oximetry monitors the need for and effectiveness of O2 therapy. Physical and emotional rest allows the patient to conserve energy and decreases the need for more O2. The degree of rest recommended depends on the severity of HF. A patient with severe HF may be on bed rest. A patient with mild to moderate HF can be ambulatory with restricted activity. Urge the patient to take part in prescribed activities, allowing for adequate recovery periods. A structured exercise program, such as cardiac rehabilitation, should be considered for all patients with chronic HF. These programs are associated with decreased hospitalizations, reduced mortality, improved QOL, and less depression. Drug therapy. The cornerstone of drug therapy in chronic HF is neurohormonal blockade. The result of neurohormonal blockade is decreased plasma aldosterone levels, decreased SNS activity, vasodilation, and sodium and water excretion. Each class of evidence-based medications has been shown to decrease mortality and morbidity in patients with chronic HFrEF. Recommendations for HFpEF primarily address symptoms and comorbid conditions. Drug therapy for chronic HF is outlined in Table 34.7. Evidence-based medications for HFrEF. ACE inhibitors. ACE inhibitors are first-line drugs for chronic HFrEF. They decrease mortality, morbidity, hospitalizations, and symptoms in patients with HFrEF. ACE inhibitors block the ROS by inhibiting the conversion of angiotensin I to angiotensin II. They reduce afterload and SVR and inhibit the development of ventricular remodeling by inhibiting ventricular hypertrophy. Major side effects include symptomatic hypotension, intractable cough, hyperkalemia, angioedema, allergic reaction involving edema of the face and airways, and renal insufficiency when used in high doses. Aging and renal insufficiency slow the metabolism of ACE inhibitors and may lead to increased serum drug levels. We monitor renal function and serum potassium levels. Examples of ACE inhibitors are listed in Table 34.7. More information about ACE inhibitors is found in Chapter 32. Angiotensin II receptor blockers. For patients who are unable to tolerate ACE inhibitors, angiotensin II receptor blockers, ARBs, are recommended. They prevent the vasoconstrictor and aldosterone secreting effects of angiotensin II by binding to the angiotensin II receptor sites. ARBs promote afterload reduction and vasodilation. The side effects are similar to those of ACE inhibitors, except that ARBs do not typically cause a cough. Angioedema is less common. Monitoring is similar to that for ACE inhibitors. Neprilysin angiotensin receptor inhibitors. Sacubitril, valsartan, and Entresto is a combination of neprilysin inhibitor, sacubitril, and an ARB, valsartan. This drug provides dual blockade of the ROS and the natriuretic peptide system. Sacubitril, a recombinant form of BNP, inhibits neprilysin, an enzyme that degrades natriuretic peptides. Sacubitril inhibition allows for more available circulating BNP. This results in decreased SVR, afterload, and CVP, and increased natriuresis and diuresis. This drug is an alternative to ACE inhibitors and ARBs in patients meeting criteria with symptomatic HFrEF and reduces death and hospitalization. Patients are monitored for hypotension, renal insufficiency, and angioedema. Aldosterone antagonists. Spironolactone, aldactone, and eplerenone, Inspra, are potassium-sparing diuretics that inhibit aldosterone activation. These drugs work by binding to receptors at the aldosterone-dependent sodium-potassium exchange site in the distal renal tubule, where they have a mild diuretic effect. They may prolong survival in patients with HFrEF. It is critical to carefully monitor serum potassium levels and renal function in patients taking aldosterone antagonists. Beta adrenergic blockers. Beta blockers directly block the negative effects of the SNS, e.g., increased HR, on the failing heart. 3 beta blockers decrease mortality in patients with HFrEF. Metoprolol succinate, Toprol XL, bisoprolol, Zabeta, and carvedilol, Coreg. These beta blockers may also increase LVEF. The improvement in LVEF is dose-related, so the highest tolerated dose should be given. However, because beta blockers can reduce myocardial contractility, care must be taken in patients with volume overload. They are usually started at low dose. Then, the dosage is increased every 2 weeks as tolerated. Major side effects include worsening of HF symptoms, hypotension, fatigue, and bradycardia. Ivabradine, Corlinor. Ivabradine selectively inhibits a particular sodium-potassium current in the SA node, resulting in a decreased HR. It can decrease hospitalizations in patients with HFrEF who are in sinus rhythm with an HR greater than 70 beats per minute and have symptoms despite optimal doses of other medications. Monitor patients for bradycardia and lightheadedness. Hydralazine isosorbide dinitrate combination, Bidil. This drug is a fixed combination of the vasodilator hydralazine and isosorbide dinitrate. It can significantly reduce mortality and improve LVEF and exercise tolerance by reducing afterload through blood vessel vasodilation. The drug is specifically effective in blacks with HFrEF already receiving optimal doses of other evidence-based medications. Although non-black patients do not see the same benefit, it may be used in any patient with HFrEF already on evidence-based medication. Major side effects include hypotension and headache. Like other nitrates, it should not be used with phosphodiesterase inhibitors, such as sildenafil, Viagra. Digitalis. Digitalis digoxin, a weak positive inotrope, acts primarily as a neurohormonal modulator that reduces the effects of the SNS and suppresses renin secretion from the kidneys. Low-dose digitalis decreases HF hospitalizations and symptoms in patients who are still symptomatic despite standard HF therapies. No mortality benefit has been found. Better outcomes occur with digoxin serum levels of less than 0.9 nanograms per milliliter. Higher serum doses are associated with increased mortality rate and digoxin toxicity. Dose should be based on body mass, renal function, and concomitant medications. The usual maintenance dose in HF is 0.125 milligrams daily. Monitor renal function and serum potassium levels of all patients taking digitalis. Concerns about digoxin toxicity are abated by the subtherapeutic dosing in HF. Medications for symptom management. Diuretics. Diuretics reduce symptoms of fluid overload and congestion in both HFrEF and HFpEF. Diuretics reduce edema, pulmonary venous pressure, and preload. These drugs act on the kidney by promoting excretion of sodium and water. Loop diuretics, e.g. furosemide, Lasix, and bumetanide, Bumex, act on the ascending loop of Henle to promote sodium, chloride, and water excretion. Problems in using loop diuretics include low serum potassium levels, ototoxicity, and possible allergic reaction in patients sensitive to sulfa-type drugs. Thiazide diuretics inhibit sodium reabsorption in the distal tubule, promoting excretion of sodium and water. They also can severely lower potassium levels. In chronic HF, the lowest effective dose of diuretic should be used. Side effects of diuretics include dehydration, hypotension, orthostasis, renal dysfunction, and electrolyte abnormalities. Diuretic resistance can occur in HF patients, necessitating dosing augmentation and the addition of different diuretic classes. Device therapy. Patients with HFrEF may benefit from implantable cardiac devices. HF patients must be on appropriate therapies before becoming a candidate for device therapy. Patients with an LVEF less than 35% are at significant risk for SCD. An ICD is recommended for primary prevention of SCD in these patients. In patients with an LVEF less than 35%, neurohormonal effects and cardiac remodeling can result in dysynchronous contraction of the LV and RV, contributing to poor ventricular filling and reduced CO. CRT is recommended for these patients. With CRT, an extra pacing lead is placed through the coronary sinus to a coronary vein of the LV. This lead coordinates right and left ventricular contractions. Patients with symptomatic HFrEF often need both CRT and an ICD. Combination implantable devices are available. Pacemakers and defibrillators are discussed in Chapter 35. Mechanical assist devices available to sustain HF patients with deteriorating function and those awaiting cardiac transplant will be discussed later in the chapter. Remote monitoring of physiologic data. Implanted ICD and CRT devices can be used for remotely monitoring HF patients. Physiologic parameters of worsening HF known to change prior to symptom emergence can predict HF decompensation and help with clinical decision making. Information from these devices can be retrieved electronically via secure websites. Examples of parameters we can remotely follow are BP, weight, HR trends, can evaluate adequacy of beta blockade. Increasing HR can indicate worsening HF. HR variability, HRV, a reduction is associated with higher risk for exacerbation and hospitalization. Patient activity level, dysrhythmias, and intrathoracic impedance, an indicator of intrathoracic fluid level, providing early detection of impending ADHF. Implantable hemodynamic monitoring is also possible. A pulmonary artery sensor can be implanted in the pulmonary artery during a right heart catheterization. It can provide information about HR, systolic, diastolic, and mean pulmonary artery pressure. Detection of early hemodynamic and fluid status changes can allow for proactive management to reduce fluid overload, which decreases hospitalizations in patients with HFrEF. Nutritional therapy. Poor adherence to a low-sodium diet and failure to take prescribed medications as directed are the most common reasons for readmissions of HF patients to the hospital. It is critical that you accurately assess a patient's diet and teach both the patient and caregiver about the importance of diet. Take a detailed diet history. Determine not only what foods the patient eats, but also when, where, and how often the patient dines out. Assess the cultural value of food. Use this information to help the patient in making appropriate dietary choices when developing an individualized and culturally sensitive diet plan. The AHA website has helpful dietary guidelines for HF patients. HF guidelines vary with regard to sodium restriction and HF management. There is agreement that excess sodium may worsen HF symptoms and facilitate an exacerbation. A low sodium intake may lead to higher adverse event rates in later stages of HFrEF. The degree of sodium restriction depends on the severity of the HF and the effectiveness of diuretic therapy. Generally, sodium intake is restricted to 2 grams per day. Teach the patient what foods are low and high in sodium content and how to read labels. Review how to find sodium content per serving and the number of servings per package. Teach ways to enhance food flavors without the use of salt, e.g., substitute lemon juice, various spices. Discuss the high sodium content of most restaurant foods. Fluid restrictions are not often prescribed for the patient with mild to moderate HF. However, fluid restrictions may be needed for stage D HF patients with persistent fluid retention despite appropriate sodium restriction. To monitor fluid status, tell patients to weigh themselves at the same time each day. To ensure valid trending, this should be before breakfast, using the same scale and wearing the same type of clothing. For patients with visual limitations, suggest scales with larger numbers or an audible response. Tell patients to call the HCP about a weight gain of 3 pounds, 1.4 kilograms over 2 days, or a 3 to 5 pound, 2.3 kilogram gain over a week. Nursing management, heart failure. Nursing assessment. Subjective and objective data that you should obtain from a patient with HF are shown in Table 34.9. Carefully review the patient's current prescription and over-the-counter OTC drugs. Chronic HF patients often take multiple other medications for coexisting conditions and underlying CVD. OTC medications known to pose significant risk to people with HF include NSAIDs, higher than prescribed aspirin doses, ephedrine, pseudoephedrine, and diet pills. NSAIDs can contribute to sodium retention and an exacerbation of HF. Review the patient's dietary habits to identify issues related to an exacerbation of HF. Explore the patient's chronic health problems as they may exacerbate HF, affecting the plan of care and the timing and choice of therapies. For example, a patient with sleep apnea may not use a continuous positive airway pressure device at night. This can worsen pulmonary or systemic HTN and lead to an exacerbation of HF. Nursing diagnoses. Nursing diagnoses for the patient with HF include impaired gas exchange, impaired cardiac output, fluid imbalance, activity intolerance. Additional information on nursing diagnoses and interventions for the patient with HF is presented in eNursing Care Plan 34.1 on the website for this chapter. Planning. Nursing care focuses on the priority problems of decreased CO, impaired oxygenation, fluid overload, intolerance of physical activity, and managing a complex medication regimen. The overall goals for the patient with HF include 1. Decrease in symptoms, e.g., shortness of breath, fatigue. 2. Decrease in peripheral edema. 3. Increase in exercise tolerance. 4. Adherence with treatment plan, including appropriate evidence-based medication and device therapies. And 5. No complications related to HF. Nursing implementation. Health promotion. Communication and joint decision-making among the patient, caregiver, and interprofessional team are integral to high-quality patient-centered care. Currently, the emphasis is on aggressively identifying and treating risk factors in the patient with stage A HF to prevent or slow the progression to symptomatic HF. By identifying patients with obesity, metabolic syndrome, diabetes, HTN, and hyperlipidemia as already having stage A HF, Goals related to a heart-healthy lifestyle can be given deserved urgency. Recommended lifestyle modifications begin with weight management, diet, and regular exercise. Often, medications are needed. Encourage patients to get influenza and pneumococcal vaccinations. Patients with valvular disease that may be contributing to HF should be evaluated for valve repair or replacement procedures. Coronary revascularization procedures should be considered in patients with CAD. Antidysrhythmic drugs or pacing therapy may be indicated for patients with serious dysrhythmias or conduction disturbances. Acute care. Many persons with HF have one or more episodes of ADHF. Common precipitating factors to HF hospitalization include respiratory infections, dysrhythmias, acute coronary syndrome, uncontrolled HTN, and non-adherence to medications and/or diet. Patients with ADHF are usually admitted through ED, stabilized, then cared for in an ICU, intermediate care unit, or specialized HF unit with continuous ECG monitoring capability. Successful HF care depends on several important principles. 1. HF is a progressive disease. 2. Treatment plans are established with QOL goals. 3. Symptom management depends to a significant degree on adherence to self-management protocols, e.g. daily weights, diet, exercise, recognizing signs and symptoms of decompensation, and drug and device therapies. 4. Precipitating factors, etiologies, and contributing comorbid conditions must be addressed. 5. Complex care needs often require care in multiple settings, increasing risk for fragmented care. And 6. Support systems are essential to the success of the entire treatment plan. Ambulatory care. Transitional care programs and protocols are designed to ensure coordination and continuity of healthcare as patient transfer between care settings. Programs that include comprehensive discharge planning, collaboration among providers, and planned prompt follow-up with HCPs have shown reduced readmission rates. Goals of ambulatory HF care include symptom management, QOL maintenance, morbidity and mortality benefit from therapy, identifying and mitigating factors precipitating ADHF and hospitalization, and closely monitoring responses to potential side effects of therapies. HF is a chronic and progressive condition that will require lifelong therapies. It is important to include the patient and caregiver in the overall care plan. Help them develop a clear action plan for response to increased signs and symptoms of impending exacerbation. A patient and caregiver guide for the patient with HF is shown in Table 34.10. Effective home health (HH) care can prevent future hospitalizations by providing ongoing assessments, e.g. monitoring vital signs and weight, evaluating response to therapies, and follow-up. HH nurses often use individualized care protocols coordinated with the patient and HCP. The protocols allow the nurse and patient to identify signs and symptoms of worsening HF, e.g. weight gain, increased dyspnea. Many agencies offer specialized HF programs. Telehealth and device remote monitoring technology, e.g. electronic scale, BP cuff, pulse oximeter, can collect physiologic and symptom data. Results can be sent to the HCP via telephone or secure website. In response to collected data, therapeutic interventions such as temporary increase in diuretic therapy can be implemented to improve functional capacity and prevent rehospitalization. Teach the patient the basic mechanism of action of medications and signs of drug toxicity in easily understood terms. Effective self-care includes proper technique in taking a pulse for a full minute, and use of home BP monitor and device remote monitoring equipment. The patient should understand specific HCP instructions on when to hold heart rate lowering medications such as beta blockers and digoxin. If patients are taking diuretic and/or potassium supplement medications, teach them the signs and symptoms of hypokalemia and hyperkalemia, including weakness, fatigue, constipation, and muscle cramping. Exercise training, e.g., CR, can improve symptoms of chronic HF. Exercise for patients with HF has been found to be safe and to improve overall sense of well-being. It has been associated with reduced mortality. Tailor exercise programs based on what the patient most enjoys doing. Teach the patient about the importance of rest periods, especially after exertion, and energy-conserving behaviors. Changes may be needed if environmental conditions involve an increased cardiac workload, e.g., frequent climbing of stairs. Consultation with a physical therapist or occupational therapist may be appropriate. Mechanical circulatory support devices in end-stage heart failure. Therapeutic options for stage D HF patients include 1. Chronic inotropic therapy, 2. Mechanical circulatory support MCS devices, 3. Palliative care and hospice that may or may not include ICD deactivation, and 4. Heart transplant. MCS devices can be beneficial to carefully selected patients for short-term management, long-term and bridge to transplant management, or as destination therapy. Patients who are ineligible for heart transplant may be candidates for lifelong MCS. Short-term MCS include IABP, extracorporeal membrane oxygenation, ECMO, and various continual flow pumps. The limitations of bed rest and the risk for infection and vascular complications prevent long-term use of these devices. Long-term MCS devices include LV assist devices, VADs, including percutaneous devices, PVAD, and transplanted devices, LAVDs, BiVADs. VADs provide highly effective long-term support and have become standard care in many heart transplant centers. The heart pump runs via a drive line that exits the abdominal wall and attaches to a system controller with patient-specific settings. VADs operate on AC current or batteries. Morbidity and mortality is significantly reduced if MCS is started before onset of severe right HF and systemic organ failure. Palliative and end-of-life care. HF mortality rates are still high. 1 in 5 persons with HF die within a year of diagnosis. The estimated 5-year survival rate is worse than for most types of cancer. Repeated hospitalizations and ED visits for ADHF can be predictive of end-stage HF. The ACCF and AHA provide guidelines for patients with end-stage CF, stage D. End-of-life discussions and management are emphasized, including advanced directives and information about advanced HF therapies, e.g., VADs, heart transplants, palliative care, and hospice.